It gives me great pleasure to welcome all of you to this afternoon's monthly Gastro Echo PBM meeting. And this is quite a special one because unfortunately our planned speaker fell ill and we only were made aware of this late last night. But Dr. Anthony Beeton, who is no stranger to the world of patient blood management, and as many of you know, a brilliant speaker, has kindly jumped in on the last minute late this morning to talk to us this afternoon on perioperative iron deficiency. Now, patient blood management, of course, as one of its strongest arms or pillars is the operative thing. And understanding iron deficiency and anemia in that particular environment is really, really critical. So, Anthony, really wonderful to have you with us again today. Anthony is an anesthesiologist in Johannesburg and specialized in the area of transplantation theology, where I'm sure blood is typically lost and sometimes needed. And with his experience, he knows how to do this often without any blood transfusion. So we really look forward to you sharing your expertise with us. We've had 52 registrations from 12 countries, and I'm sure many of them will still join us as we go forward. But I would like to welcome Anthony and ask you to share your screen. We look forward to hear what you've got to share with us. Thanks.
Thanks very much, Vernon. Give me just a moment to get to the beginning of my talk. Thank you, everyone, and thanks to Chris and Vernon. And at 10 o'clock this morning, I thought I was going to be doing a liver resection at this time this afternoon. So it did come as a bit of a surprise to me. I feel a bit like a member of the bomb squad in the rugby, being called on at the end of the second half, probably only enough energy to last for about 20 minutes. Are you seeing my screen?
Yes, we are.
Okay, great. So what I'm going to do is I've pulled together a whole bunch of slides in the last hour looking at perioperative anemia and perioperative iron deficiency. And the slides are going to come as much a surprise to me as to you, I believe, because I'm not entirely sure what order they're in. I have a couple of disclosures. I have received payments and sponsorships in the past from the companies listed here who are involved in the iron world. So please take what I say with due caution. I believe that we're all familiar with this triad of independent risk factors for adverse outcomes perioperatively: anemia and iron deficiency, transfusion, blood loss, and bleeding. And the three are not only individual factors in terms of producing adverse outcomes, but they have a pernicious way of adding up and leading one to the other, in fact, in either direction. So anemia and iron deficiency can increase the risk of bleeding. You know, anemic patients are more at risk for bleeding. Blood loss, of course, can lead to transfusion. And transfusion, especially if the hematinic deficiency is not corrected, can lead to a post-operative iron deficiency. And as Vernon has said on a previous occasion, anemia is just about the biggest deal there is. It's the second commonest disease on the planet after dental caries, and it produces a massive burden of disease. And it was estimated that about between 35 and 40% of the population of the planet in 2015 was afflicted with anemia, of which just over half, or perhaps 60%, had iron deficiency anemia. And you'll see later in the talk that for every patient with iron deficiency anemia, there is another patient with iron deficiency without anemia. So in fact, the burden of iron deficiency is staggeringly large. This is the previous global burden of disease study, just to show that the green segments are iron deficiency anemia, but iron deficiency still is by far the biggest player in terms of causes of anemia. And there hasn't really been very much change in terms of iron deficiency anemia in the last 25 years. Most of the change has come in GIT and parasitic disease control in terms of etiologies of anemia. And anemia can afflict everyone across the board, but we know that women, particularly women of childbearing age, and children are particularly susceptible to anemia. And this group is also very politically charged, and it really makes the job of PBM easy, because we're trying to reduce suffering and death in our children and our women. Really, it's got to be a concept that is shared by both doctors and politicians alike. So the question is, what is the influence of anemia in our perioperative population? And I'd put this up as a slide when there was an option for people to give answers, but in fact, all of the answers are correct. And it really depends which group of patients in which country we're studying. So we've seen this before. This is the South African Surgical Outcome Study, looking at consecutive admissions for non-obstetric, non-cardiac surgery over a week in a large group of academic hospitals across South Africa. And they just collected a lot of data on the patients. And one of the pieces of data they collected was the incidence of anemia. And in South African patients presenting for elective surgery in state hospitals, the incidence of anemia was more than 50%. And that was about all we knew about the anemia in these patients. But this study that is being coordinated locally by Matt Gibbs at UCT Anesthesia, and in fact they're busy recruiting centers to get involved in it, will dig down in with much more granularity into the incidence, the type of anemia, and the impact of the anemia on our patients' outcomes. So those of you who are interested in getting involved and getting your patients enrolled in the study, please get hold of Matthew Gibbs at UCT Anesthesia. So I said earlier that iron deficiency is seen in about twice as many patients as we see iron deficiency anemia. In cardiac surgical patients in France, the rate of iron deficiency anemia was 20%, the rate of iron deficiency about twice that. But if they presented with cardiac failure, the rate of iron deficiency was at least 50%. And iron deficiency in this group makes a massive difference to their quality of life, because iron is not just about making hemoglobin. And these patients' suffering was dramatically reversed rapidly with intravenous iron therapy, way before any impact on the hemoglobin in these patients. In another study in Spain, Manuel Munoz, they had iron deficiency in 42% of their non-anemic elective surgical patients. So it's a really common, probably the commonest comorbidity by a long way that our perioperative patients present with. Munoz's study showed that there was iron deficiency anemia in 36% of the patients, more so in the women, and that most of the anemia was in fact iron deficiency anemia. But the highest rates were in the gynecological and colorectal cancer group and in elderly ladies with fractured hips. But way commoner and way more onerous and way less studied than preoperative or intraoperative anemia is postoperative anemia. And postoperative anemia is thought to probably occur in 90% of major surgical patients, and it has a dramatic impact on duration of recovery, quality of recovery, development of wound complications, sepsis, etc. And the two biggest risk factors for postoperative anemia, not surprisingly, are preoperative anemia or hematinic deficiency without anemia, and blood transfusion. And it would appear that there is a compelling signal for a variety of adverse consequences of postoperative anemia. Certainly prolonged hospitalization, unscheduled readmission, post-operative cardiac events, and mortality from other causes as well. And as you'll see a couple of times in some of my subsequent slides, duration of hospital stay is a very good surrogate for a whole host of adverse reactions in anemic patients post-operatively. I'm a bit embarrassed to put this slide up with Vernon chairing the session, but it was really just to emphasize that iron is not just about synthesis of hemoglobin. Iron is involved in enzyme systems, in cellular respiration, etc., in immunological function. And iron deficiency can present with anemia, but generally will present with fatigue, even if the patient's not anemic, more so if they are. And there is enhancement of a wide range of inflammatory processes in our iron deficient patients. We own about 3 or 4 grams of iron, which is distributed as I've stipulated here. I'm not going to get much into iron physiology, but just a couple of comments. And the first is gastrointestinal iron absorption is not an easy business. Heme iron is easier to absorb than non-heme iron, but it's really difficult to absorb non-heme iron. And you can only absorb 1 or 2 milligrams a day, and it's got to get past all of these various letters here, various gates, porter. It's stored in certain ways. It's then released into the circulation under the guardianship of a variety of guardians who open and close the gates more or less at their whim. And then it has to get into a suitable state to be carried around the body. And even if it gets to the areas of iron stores in our patients, when we need it, it may not be available. And it may not be available because a host of disease processes which have inflammation as a common factor result in increased levels of hepcidin, which essentially just closes all the doors. So it keeps the iron locked away where it's unavailable for marrow utilization and for hemoglobin synthesis. And eventually, if you make a patient significantly iron deficient, they will become anemic. But a lot of things happen before they become anemic. And there is a sort of a ladder of events that occurs. And the first thing that occurs is the patient just doesn't feel great. They feel fatigued and depressed. And that's because a lot of enzymes involved in cardiac function, in enzyme synthesis, catecholamine synthesis, require iron as a cofactor. And then gradually, as your iron stores diminish, you start making smaller red cells, and then eventually your hemoglobin concentration falls. And in the absence of iron, you don't mount much of a reticulocyte response. So how much hemoglobin and iron do you need if you're embarking on major surgery? And we kind of, I think, got ourselves a bit confused, but between what you can do safely, what you can do barely safely, keeping the patient alive, and what you should do. And there definitely is only one correct answer in this question, and that is a normal hemoglobin. You can do surgery at a hemoglobin of 10 with keeping the patient safe. You may, in young, healthy patients, be able to do surgery at a hemoglobin of 7, but that does not mean that that should be our target, or that we should have any pride in doing surgery on patients with these lower hemoglobins. We know that patients who have chronic anemia can actually cope well with their anemias, and that's where these numbers like 10 and 7 arose from, that there are compensatory mechanisms in place to cope with anemia in a sort of a non-stressed environment, non-surgical environment. So that's right shift of the oxygen hemoglobin dissociation curve, that is increasing capillary density, reducing the distance across which oxygen has to diffuse to the cells, and intracellular processes, which we kind of globally lump together as preconditioning, that allows you to function in a less aerobic environment. But that does not mean that you can do that in the perioperative setting. And this graph just essentially shows that until your hemoglobin drops below 70 grams per liter or 7 grams per deciliter, there is really not much of a mortality signal in the non-stressed environment. But things are different in the perioperative phase. And this meta-analysis of about 1 million patients in 24 studies showed conclusively that in the perioperative phase, not only was anemia common, but anemia was associated with a host of adverse outcomes, including mortality. And these are the data presented graphically. And the interesting thing about this is that the inflection point for increases in mortality and morbidity in the surgical population was the normal hemoglobin level, a hematocrit of 38 in this case. So unlike chronic anemias, that inflection point was around about a hematocrit of 21. Here it is a normal hemoglobin. And obviously, the worse the hemoglobin, the worse the outcome. So patients with severe anemia would have all of the adverse outcomes accentuated versus normal hemoglobins or mild or moderate anemias. This table does not really bear in mind the impact of other comorbidities or transfusion. It just looks at anemia, and clearly patients with anemia often carry other comorbidities and in fact receive greater amounts of transfusion. Just to look at what sort of adverse events we've seen commonly: cardiac adverse events, septic, hemorrhagic, multi-organ failure were dominant adverse events. So what did we see in the South African surgical outcome study? Again, I said that the anemia incidence was about 50%. Over 60% of these were iron deficient. The anemic population had a 66% increase in mortality and a 50% increase in ICU stay. So what about, it's pretty clear that anemia is associated with perioperative death and perioperative adverse events. What about non-anemic iron deficiency? And I guess the answer here is there aren't that many studies, and we often don't know that our patients have iron deficiency because we don't test for it preoperatively, and we really should. So you get a patient who comes in with a malignancy with a hemoglobin of 12, they feel awful and fatigued, and we say, well, you're feeling fatigued because you've got a malignancy, but they may in fact be feeling fatigued because they've got iron deficiency. So there are not as many studies, and hopefully Alice will help us to sort of study this further. But in a cardiac surgical cohort, there were definite adverse implications of iron deficiency without anemia. They needed more transfusions, and they stayed in hospital longer, and that prolonged hospital stay is probably an indication of the development of adverse events. So how do we approach anemia perioperatively? And really, there are two approaches. There's the patient blood management approach, which is a really scientific, multi-sectoral striving to defend and augment the patient's own red cell mass and avoid transfusion unless it's required. And then there's the transfusion paradigm, where essentially we look at transfusing against perioperative targets. This is a picture of patient blood management showing that there are three pillars. The first is about getting the red cell mass right, and that is really the low-hanging fruit in patient blood management. The second pillar is techniques to minimize intraoperative blood loss and bleeding. And the third is maximizing the patient's physiological reserve, oxygen therapy, inotropic therapy, in order to allow them to cope with lower hemoglobins. And only the very bottom sector is about transfusing the patient. And I'm not an anti-transfusionist. I'm just anti-transfusing based on a particular number, unless that number happens to be a rising lactate or a falling diastolic blood pressure. And why am I sort of disinclined to use hemoglobin to fix a number? And the reason, disinclined to use blood to fix a number, and the reason is that blood is a transplant, and I'm a transplant anesthetist, so I should be keen on transplants. This is one that I'm not keen on because it comes with a host of potential adverse events, even in leukodepleted blood, well cross-matched leukodepleted blood. And this is really a topic for another day, but we know that red cell transfusions are not by any means innocent. And in fact, all they do is fix the number. They fix the hemoglobin level. They do not fix the hematinic deficiency. And in fact, if you transfuse a patient up to a hemoglobin of 12 and send them home, and you check them in 6 weeks' time, the hemoglobin will be 8 or 9, and they'll be feeling terrible. And the second thing it doesn't fix is oxygen delivery, because transfused blood is left shifted on the oxygen hemoglobin dissociation curve and is very reluctant to release oxygen. So essentially, if you don't need to transfuse the patient to resuscitate them, then you should avoid at all costs using blood and try and fix it by correcting the hematinic deficiencies. The commonest cause of transfusion in theatre is preoperative anemia. And just imagine how many units of blood product we could save if we didn't bring patients to theatre with preoperative anemia. Now, obviously, that's not always possible. We have emergency situations or very urgent situations. But in patients who are having elective or semi-elective surgery, and that even includes cancer surgery, there is time to make a massive difference to their red cell mass preoperatively and avoid or reduce the need for blood transfusion. And there's, just to emphasize again, that anemia and transfusion both have adverse effects, both on patient survival and on the development of adverse events. So there kind of are two schools of people in the world of transfusion and hemoglobin and anemia. The one are the patient blood management people who will avoid transfusing unless they have to. And then there are the transfusionists who really are all about determining what is the trigger for transfusion. And this conference in Frankfurt in 2018 was a transfusionist congress. And it was designed to determine what and how much one should transfuse at different settings. And essentially, what they said is we should virtually do away with transfusion triggers, or at least lower them to very low levels. And that we should abandon less restrictive transfusion targets like hemoglobins of 10 or 12, even if the patient has coronary artery disease. And they also advocated worldwide implementation of this, of patient blood management. So we are doing that in South Africa to a greater or lesser extent, in our own small ways. But does it make a difference? So does trying to improve the patient's red cell mass by iron or other hematinic replenishment make a difference? And this is an orthopedic study from Singapore, I think, looking at arthroplasty patients. And they looked at two time cohorts. They looked at a time cohort when they utilized the transfusion paradigm, and they looked at the implication on hospital stay. And they saw that if they gave the patients 1 unit of blood, hospital stay was increased by 4 days. If they gave them more than 2 units of blood, it was increased by 8.5 days. And then the more recent cohort was a PBM cohort. And what they really looked at is if you manage to improve the patient's hemoglobin pre-operatively, what impact does that have on length of stay? Now bear in mind that in this group, the average length of stay after a knee replacement was 3.9 days. And a lot of that relates to mobilizing the patient, physiotherapy, and so on. So it shouldn't be a surprise that the increases in hemoglobin were not associated with massive numerical reductions in length of stay. That a 3-gram increase in hemoglobin via iron replenishment only produced just over a half-a-day reduction. But that is a 15% reduction in length of stay, and it probably means that those patients had less perioperative adverse events. This is another group, also an orthopedic group, and it's quite a complicated slide, and you'll just have to try and sort of sit tight as I remember how it works. Essentially, what they did is they randomized their patients post-operatively into a control group and a group who was going to receive post-operative intravenous ferric carboxymaltose. And the deciding factor was whether the patient's hemoglobin post-operatively was greater or less than 10 grams per deciliter. So if it was greater than 10 grams per deciliter, they didn't receive iron, they received what's called conventional therapy, which is essentially transfusion every time the hemoglobin drops below 10. And the ferric carboxymaltose group received ferric maltose, and they were only transfused if their hemoglobins dropped below 7. And essentially what we saw is that at the 6-week period, despite the control group receiving 4 units of blood for every one that was received in the iron replenishment group, who started more anemic, the iron replenishment group, in fact, were less anemic, significantly less anemic than the control group. So if there's ever a sort of a study, although it's a complex study, there's ever a study that confirms that it's worthwhile going down the PBM route, then this is perhaps the study. This slide attempts to coalesce a couple of different perioperative journeys in orthopedic patients. And on top of the double solid line is a group of patients who presented, who were assessed preoperatively. If they were anemic, in other words, if the hemoglobin was below the normal hemoglobin for that patient, they received erythropoietin and hematinics. And amongst the hematinics, the ferric carboxymaltose was intravenous. And in the group below the double solid line, they attempted to fix the hemoglobin using oral iron. And I think the big thing to see is that on hospital admission, the patients who received intravenous iron as part of their therapeutic intervention had a 0% anemia rate. So the big differences between these studies were, of course, the route of iron replenishment, the choice of the intravenous iron formulation, because in the lower group, if they didn't respond to oral iron, they were given intravenous iron sucrose. And essentially, one looked at a full PBM strategy and the other at a somewhat pared down PBM strategy. Oral iron is a perfectly acceptable approach to chronic anemia, to chronic iron deficiency. It just has a little bit less utility in the perioperative setting, particularly where surgery needs to be done fairly urgently, because it's actually, frankly, impossible to give a patient enough iron to correct a significant iron deficiency over a couple of weeks preoperatively. And we know that there are plenty of problems with oral iron therapy. So oral iron is really effectively useless perioperatively unless you have a couple of months to prepare a patient for their hernia repair surgery. It's also useless in the late 3rd trimester of pregnancy. There's a kind of a general rigor that goes around the population when you speak of intravenous iron, though, because they know about anaphylaxis. They know that intravenous iron is bad for you. They probably actually don't know about anaphylaxis at all. What they know about is iron reactions, is Fishbane reactions, and there are big differences in the different iron formulations in terms of the rate of these reactions. And all of the modern iron compounds, the carboxymaltose, isomaltoside, and ferromoxitol, have a really low rate of transfusion reactions or complement-mediated Fishbane reactions because of the low incidence of, or the low percentage of free or labile iron. But the critical thing is to diagnose the preoperative anemia or the preoperative iron deficiency. And for that, you need a pre-op clinic of some sort or another, or at least a surgeon who measures the hemoglobin and iron levels at the time of presentation, so that we have time to sort of utilize a patient blood management protocol on the patient. And these couple of slides are just a couple of different options, just to say that if a patient's anemic and they have a low ferritin, they are iron deficient and they need iron, and you should give it to them the way it works best to get them iron replete by the time they have surgery. If their ferritin levels are higher and they have markers of inflammation, they are almost certainly also iron deficient, and they also need to receive intravenous iron. They may also need some erythropoietin in order to utilize that iron optimally. This is what we do at our hospital, and our surgeons have all bought into this, and it seems to be working well, but I mean, that's not really science, that's just kind of anecdote. But what we do at the time of patient presentation. And our hospital deals a lot with patients with anemias related to malignancy. We do a full blood count and a tick count. And we also pull a second tube of blood. And if the patient's even marginally anemic, we measure their serum ions. We've now moved to measuring their serum ions even if they're not anemic. And if they fall into an iron deficient or a potentially iron deficient group, the ones with the higher ferritins with a raised CRP, we give them intravenous iron, one of the 2 formulations that are available to us. And we reassess the hemoglobin and reticulocyte count at 3 weeks. And if the hemoglobin response is not greater than 2 grams per deciliter, and there is time to do it, we repeat the iron infusion and we give them a dose of erythropoietin. It is a little bit of a shotgun approach. We in fact find about an equal amount of iron deficiency anemia and sort of myelodysplastic anemias in our malignancy patients. And just to finish off, and I'm sorry if my presentation seems to have been a lot shorter than it was scheduled to be. I'm going to present a couple of case studies. And the first is a patient from my practice from the days of the transfusion paradigm. And it was a woman in her 50s who unfortunately needed a pancreatic duodenectomy. She had an iron deficiency anemia with a preoperative hemoglobin of 10.2. So we ordered the ubiquitous 2 units in theatre and 2 units on standby. She went for her surgery, which was relatively bloody for a Whipple's procedure. She, in fact, received 3 units of blood in the perioperative phase. She spent 18 days in hospital, 10 of them in ICU, and her discharge hemoglobin was 8.9. A patient just 3 or 4 years later who had the benefit of the PBM paradigm for resection of a massive retroperitoneal sarcoma, also a woman in her early 50s, had preoperative iron deficiency to a hemoglobin of 9.9, received a dose of intravenous, I think it was ferric carboxymaltose 3 weeks preoperatively. She had a nice hemoglobin response. We went ahead and did the surgery with this blood on standby at the blood bank using cell salvage. She lost a lot more blood than our Whipple's patient did, 1.9 liters. We returned 650 mils of salvaged packed cells, and she was discharged not of day 5, but on day 5 with a hemoglobin of 10.2. So 2 fundamentally different outcomes. She had a hemoglobin checked at 30 days post-op, it was 10.7. She was on oral iron at the stage. So we in fact gave her only a single dose of intravenous iron. She was happy to battle through with oral iron in the post-operative phase. So essentially, either paradigm is available. It really is your choice. But patient blood management makes so much sense from the perspective of being a proper doctor apart from anything else. And the critical thing in patient blood management is screening for it and typifying the anemia and then correcting it at the first point of contact with the healthcare system, which is often the general practitioner or the general surgeon when the patient is referred for their surgery. Thank you very much for your attention.
Anthony, what a tour de force. Fantastic talk. I've been really
I must rather just train through and focus on my stroke and
think,
do all those things.
let's just quickly see if we can
I'm
mute.
just going to try and...
And does he?
Perfect. Okay.
There we go. Great. Well, wonderful. Anthony, fantastic talk. Thank you so much. Can I hear from anyone in the audience if you have any questions or thoughts? And Anthony, perhaps I can start and say, when you plan for a liver transplant, as an example, obviously the situation might arise where you might still need blood. How do you go about this practically nowadays within the PBM paradigm? What do you do?
Okay, so nowadays are actually different from 2 years ago because COVID has actually planted a large puncture in our cadaver transplant program. So our transplant program now is really largely a living-related donor program. But that's great because we have the time while we're working up the potential donors to also attend to our recipients. The transplant population are quite complicated though, because they're not, I mean, obviously we have things like Wilson's disease, we have patients with hemochromatosis and things who clearly may be anemic, but may not benefit from receiving intravenous iron. But we do replace the patient's hematinics. If they don't have a contraindication, they get intravenous iron as long before their surgery as possible. So with the related donor transplants, we give them a month before surgery, and we target a normal hemoglobin. It's not always as easy to reach in our transplant patients as it is in patients with other malignancies or for other general surgical interventions. And then what we used to always order 10 units of packed cells and 10 units of FFP and 10 units of cryoprecipitate and 3 mega units of platelets for a transplant, and have them in theatre. So what we've done in the interim is we initially were able to halve the amount of blood that we ordered to have in theatre and keep more on standby. But now with the use of pre, intra, and post-operative point of care devices, we are able to use a lot more targeted kind of procoagulant usage in these patients to further decrease our red cell use. So, I mean, in the last 6 months, we've used from 0 to 23 units of packed cells in different transplant patients. We try by all means to avoid using bank blood transfusion and blood product transfusion, but obviously patients who've got massive splenomegaly, hypersplenism, portal hypertension, they're going to bleed, and they may well need blood to resuscitate them hemodynamically. We use blood as a hemodynamic resuscitating agent, not as a targeted transfusion technique. And we've got like a hotline to the blood transfusion service, so we can order relatively little in terms of products for theatre, and just use our point of care devices to assess if we're going to need more and get more into theatre in time. Unfortunately, we haven't yet managed to start a transfusion without having some product in theatre. We need the reassurance of having some product in theatre, because if you prang the IVC behind the liver, intravenous iron is not going to sort the problem out.
No, thank you very much. Could you perhaps also just share your personal experience with the use of tranexamic acid and where you use it and how you use it?
Yeah. So I use it quite freely because I actually don't really believe that tranexamic acid is a procoagulant in its own right. It's an antifibrinolytic, and I know there are a lot of people who've expressed concern that you're going to increase the potential for thrombotic complications, but I don't really believe that there's a huge amount of evidence that in fact happens with appropriate doses of tranexamic acid. So where I use it in my practices, I use it in adult transplantation. I use it in adult and pediatric transplantation if there is point of care evidence of fibrinolysis. I use it in major orthopedic surgery, so that's primary and revision arthroplasty surgery. And I don't do very much obstetrics anymore, but I used to use it like dishwater in obstetrics as well. And obviously it's used in cardiac surgery, and it really, I honestly believe it's a low-cost, low-risk intervention that has a substantial benefit in terms of saving units transfused and therefore also saving morbidity. Sorry, just
Wonderful.
One other thing. We use it a lot by infiltration in cosmetic and non-cosmetic surface surgery. So patients who are having big tumor resections in the sort of muscle component, we infiltrate the area around it with a combination of adrenaline, local anesthetic, and tranexamic acid, because local fibrinolysis is often a problem with big raw surface areas. And so we add it into our infiltration solution in those patients. And of course, patients for facelifts and tummy tucks and various cosmetic procedures,
Sure.
where transfusion would be completely anathema.
That's very interesting. So how do you physically mix it and use it in that setting?
So what we do is we mix a volume of dilute local anesthetic. So we use a safe dose of local anesthetic in 1 or 2 liters of saline with between 1 and 4 milligrams of adrenaline and 1 or 2 grams of tranexamic acid. So you're giving fairly dilute tranexamic acid, but in fact we published a study last year where we looked at the extent of bruising and drop in hemoglobin in patients where we use this technique, and it was definitely beneficial.
Sure.
And that was published in Plastic and Reconstructive Surgery.
Anthony, I would really appreciate it if you could share that with the group.
I'll drop that, yeah.
Because I think there's something about the use of locally applied tranexamic acid that we've got a lot to learn about. I remember we published some stuff a couple of years back, and then Prof. Marius Kutsia, who was going to speak today, actually wrote a nice follow-up letter about the use of tranexamic acid locally in the mouth or the nose, crushed and locally applied. And I was recently had an interesting situation with a colleague of mine, one of our PBM team members, Dr. Marius Wasserfall, who uses tranexamic acid as an kind of an enema in people on palliative care, but with rectal bleeding from colorectal cancer. And in one patient, he's used it 3 times on, a couple of weeks apart, and every time was able to stop that local bleeding and provide a lot of comfort to the patient. And I think there's really something there and something in it.
Yeah. Sorry to jump in. When I was writing this paper on topical or tranexamic acid infiltration, I actually had a good look at the literature, and it has been instilled into virtually every natural and surgically induced cavity that there is. So for dental surgery, for those persistently bleeding sockets, for tonsillar surgery, tranexamic acid on a swab into the chest of patients having cardiac surgery or revision cardiac surgery or pericardiectomies. I don't think that there is anywhere that it hasn't been used, and always with claimed benefits. And we certainly have seen benefits.
Fantastic. Chris, I think we should make a note for our next national PBM meeting that Anthony speaks to us about the locally applied and perhaps systemically applied use of tranexamic acid.
Okay.
Anthony, just you got some work cut out for you.
And I'll drop it onto the PBM group.
Fantastic. Look forward to that.
Yeah.
Great. And then Wisdom Forward Mudombi is asking your thoughts on tranexamic acid in GIT bleeding, varicose and non-varicose. I don't know if you or Chris wants to answer that.
Yeah. So, I mean, you obviously somewhat preempted that. Varicose bleeding, so varicose bleeding is a problem, obviously, because a lot of it is hydrostatic in nature. And I'm not sure how much topical tranexamic acid will work when you've got 40 centimeters of water pressure coming through a breach in the vascular endothelium. But in terms of non-varicose bleeding, I think it really will be beneficial, because those large raw surfaces encourage local fibrinolysis, and I think that can work well in that situation. I don't have experience.
Okay. No, thank you very much for that. I think there's been some work done on acute upper GI bleed, which did not show benefit for tranexamic acid, but what you're saying makes total sense to me. You're not going to stop a spurting varices, varix. But if you've got raw surfaces, it might certainly prove useful. I want to ask Chris Cassianides, Prof, do you want to just quickly share or remind our audience about this weekend's SPE meeting?
Well, have you finished, Vernon? Do you want to?
Well, let's have an advertising break while people gather their thoughts.
Okay.
Maybe somebody, I've got nothing in the chat box at the moment.
Yeah. Okay. So just to all our GASA members, we have our SPEAR GI Hepatology Fellows postgraduate course this weekend, Friday, Saturday, Sunday. So we're inviting all our fellows and all our colleagues in GASA who are interested in teaching to please join in virtually. The advert has gone out, the link has gone out, but if you have any more questions or queries, please forward them to Cheryl Valentine. But we look forward to you all joining in Friday, Saturday, and Sunday, and we will be dedicating a Gecko platform for fellows, particularly on a separate platform and a separate day. We'll be part of the Gecko teaching, but will be for fellows only on a separate day, and Masheko Seshedi from Cape Town will be launching that at the SPEAR meeting this weekend, and we're hoping to begin that in the new year. So there will be a separate fellows GI hepatology Gecko teaching platform in the pipeline. Thank you very much, Vernon.
Great, thank you very much, Chris. That's exciting. There's a question from Wisdom. How does one join the PBM group? So we have a PBM WhatsApp group where we share new data, studies, things to take part in. This week I shared a nice new app for transfusion. If you want to join the group, you can email me and I'll quickly put it in the chat at vernon.low@uct.ac.za. There it is. You can just send me. I usually like to introduce any newcomers. So just let me know who you are, where you work and what specialty you are, and send me your mobile number. And then I'll happily add you to that group and make you aware of anything coming up. We always advertise this particular meeting there as well, which you can then forward to your friends. So that will be great. I'd also like to just encourage everyone to please give feedback on this session on the link in the chat box that was shared by our ECHO India team. We'd love to get your feedback. We always want to try and make things better. So let me see if there's any final questions. Anybody that's got something to say or share or comment or share from their own experience? If not, I would just like to say a huge thank you again to Anthony for coming in on this short notice, really. And what a fantastic talk for someone who literally had 4 hours notice before he had to give it. It's amazing. And we look forward to hearing you again, Anthony, at our next PBM meeting. I'd like to really thank Chris Cassianides, who's been the driving force with GASA and the GASA Foundation for giving us this opportunity once a month to speak on patient blood management. Thank you, Chris. Thanks for everything you do for Africa, or for Sub-Saharan Africa in particular, with regards gastroenterology and patient blood management. Also like to thank the Project ECHO, University of New Mexico, as well as our ECHO India team for all your help, and remind all of you that the recordings of this and previous sessions are available on the Gastro Foundation website, so you can go back and listen to it again or share the link with colleagues. Also, a special thanks to sponsors Takeda, Asino, Amgen, Equity, Aspen, who in their different ways are helping us make this possible. That's really fantastic. So with that, last but not least, all our participants, as I said before, we had people register from 12 different countries. It's really wonderful to have all of you here. Big thank you, and we look forward to the last, I think we've got 2 or 3 more sessions, no, probably 2 or 3 sessions left for the year. We will advertise them in due course. They will be completely different topics, but all related to PBM. And then are, of course, as usual, the many gastroenterology and hepatology sessions as well to look forward to. Thank you very much, everybody. Have a wonderful evening, and we look forward to seeing you again. Bye-bye.